So I'll start, and then Emma will talk about the methods, and then I'll come back to talk about the recommendations. And I hope everybody got a chance to get a brochure that is circulated there, and you can fold like this, and it becomes like a nice brochure with all the recommendations from the guideline. So the outline for this presentation today, we'll talk about the rationale, why the WHO decided to do this guideline, the methods that we use and we employed here at the Institute for Working Health, and then we'll talk about the guidelines recommendations. So the background for this starts back in 2006 when the United Nations got together and they put together the Convention on the Rights of Persons with Disability. This document that was just completed 10 years last year was a document that is legally binding, and the intention is that every country that is affiliated with the United Nations would abide for this document. It's basically a human rights document for people with disability. So it started with the General Assembly in 2006, and then they start collecting signatures from, how the UN does. They go collecting signatures from countries, and it entered into force in 2008. And what it says is the purpose of this, it has many articles, I copied a few of them here, is to promote, to protect, and to ensure the full and equal enjoyment of all human rights and fundamental freedoms by all persons with disabilities, and to promote respect for their inherent dignity. So when you see these people, you probably recognize these faces. You don't see them as disability. You see them as people who are contributing to society, making great things, but they have significant disabilities. So that's the intention, that one day every person in the world with a disability will be seen like Michael J. Fox or Stephen Hawking. So what is unique about this convention is that it's both a development and a human rights instrument. So as you know, we have a Canadian Commission of Human Rights. We have an Ontario Commission of Human Rights. So they look at these documents as background for what should be developed. It's also a policy instrument, which is cross-disability and cross-sectoral, and it's legally binding. I'm not going to the details because this is just background, why the WHO developed that guideline. And what the convention defines as disability is very broad. It's not just a physical impairment, it's not just a mental impairment. It's an interaction between a society and the individual. And I copied here some things that are related to work, because I knew I was going to talk to an audience today that is interested in work and health. So, for example, people who use wheelchairs, they may not have difficulties to participation in work, for example, in gaining employment, not because of the wheelchair, but because there is an environmental barrier for them to go to work. Or, if I take out this, I'm completely disabled. 100%, I cannot do what I do. I can't drive, I can't write, I can't use the computer. So when I put glasses, so people with sight problems, if you give them a prescription for glass, they can work, they can participate, they can be normal, and you don't even realize that they have a disability. So the convention also, I copied some things that are related to work, but in the Article 27 it says that there is a right. It's a right for persons with disability to work on an equal basis with others. And this includes an opportunity to gain a living by work freely chosen, whatever they choose, and is accepted in a labor market and work environment. Even if they choose to be self-employed, okay, so they can be self-employed, people with any disability, physical or mental. So last year, 2016, this is a map of the world with every country that signed the convention, yellow. Those who signed the convention and have a protocol, and those who ratified is blue, and ratified and have a protocol in red. So we want to see the whole world red. Canada is still blue. United States is still yellow, but they're doing a good job. But you see, the whole world is not red yet, and there are even some countries here that did not even, sign the convention yet. So there's a long way to go. In 2011, the first ever world report on disability was produced. So this is so this was an intention to say, okay, so the convention says people with disabilities need human rights. How many people with disability exist in the world? So the WHO and the World Bank got together and created the first world report on disability that was published in 2011. And they found that it's just 1 billion people. So 1 in 7 living in this world. That's not just the problem, because 80% of this 1 billion people live in low and middle income countries. People with disability, they have the same healthcare needs as other people, maybe a few more healthcare needs, but they are twice more likely to find inadequate healthcare providers' skills and facilities to care for them, 3 times more likely to be denied healthcare, and 4 times more likely to be treated badly in the healthcare system. These are where the surveys came from. So you see that the numbers are pretty much 15%. If they do some surveys, they find some lower numbers, but those surveys are probably inaccurate, but 15%. And I like this picture because how many people still find her beautiful? Snow White, is she still beautiful? Would the prince still like her if she was in a wheelchair? So that's what we want to see, right? Maybe a Disney movie with a disabled princess. In terms of age and sex, it's really bad. The person will be really, in a bad situation if the person is a woman, female sex, because females have more disability than male. If they live in a low-income country than a high-income country, and if they're older. So being older, female, and poor is really bad. Chances of being disabled are super high. And these 2 ladies, they are promoting inclusion of people with disability in low, middle-income countries, focused on women with disability. Education, so if we look at how many people get education, let's just see male, living in high-income country, not disabled, 72% get education, okay? And the years of education, 8 years on average. Men, high-income country, not disabled. But now, if you compare it with a female, disabled, in a low-income country, 32% get education, and the average school years is 4 years. Let's talk about Chapter 8 of the World Report on Disability. The whole Chapter 8 is about work and employment. And that's a person with mental disability. We know because some facial traces, but it's inclusive and he's working. So the Chapter 8 of the World Report on Disability talk about employment for people with disabilities. So if we look at Canada in 2003, the overall employment rate was 75%, and a person with disability, so among people with disability, was 56%, so lower. So the employment ratio is 75%, which is just this one divided by the other one. How many people are employed? From those who are employed, how many have disabilities? So 75% is the employment ratio. And this is alphabetical order, but you see Australia, not bad. But when you look at other countries, like Poland, 33, Peru, 37, Spain, 44. Zambia is a little bit outlier. It's 81. The ratio is 81, but that's because the employment ratio of the general population is low. So there are some things that can be done better. Ideally, the ratio would be 1. There's no difference in terms of employment just because a person has a disability. What about when we look at this employment by sex and age? We look at, it's similar to the education levels that we saw before, but if a person leaves, this is a teacher in a wheelchair, and she's a great teacher for this class. You should see her YouTube video. A person living in a high-income country, not disabled, males, Employment rate is about 53%, females less, and then there's the working age, 54, 57, and then lowers when they are getting older. But in low-income countries not disabled, it's interesting that it's a little bit higher for men, but it's similar for the other ones, except for 6 years and older. But when you look at disabled people, it drops dramatically for low and high-income countries. Okay, so we know that already people getting to, especially if they are disabled, they're not participation, chances are they're going to become poor. And disability management is one of the interventions that work for integration, and effective disability management includes case management, education of supervisors, workplace accommodation, early return to work with appropriate supports. And disability should not be an obstacle to work. Should be recognized as a health condition. And that interacts with the contextual factors, should be distinct, should be distinct from eligibility and receipt of benefits, should not be an obstacle to work. So the World Health Organization, together with the World Bank, decided that they needed to have guidelines. Guidelines to recommend to those countries what kind of services should be provided for disability management, prevention, treatment, and reintegration of people. Because some countries, they don't even have facilities for rehabilitation. And the World Bank decided, okay, if the WHO does those guidelines, we'll give the financial incentives for those countries to create those services. But you guys, WHO do the guideline. So one of the mandates of WHO is to develop guidelines, but also to provide technical assistance, tools, and approaches for the member states, help them to implement those things. So that's how we got into the scene.
Are we okay? Yeah. Okay. So I'm going to talk just very briefly about methods because I know everybody really wants to get to the meat of the presentation. So as a result of what Andrea had been talking about, the WHO put out a call for research proposals. So you'll see this was, the call was due the end of January 2013. So the Institute submitted a proposal around January 30th of 2013 and to help develop the evidence, or the best evidence to support the development of a guideline. Oh, that's not what I meant to do. There we go. So the rationale, I think Andrea has already gone through a lot of this, but it was really the things that we want to focus on was to, with a focus on low and middle income countries, strengthen the service delivery and ensuring that it is adequately financed, which is a very important component, to ensuring that rehabilitation is available and affordable to those that need it, again with an emphasis on low and middle income countries. And to bring that about, we would develop an evidence-based guideline. So what does that mean? So the objectives of the recommendations was to provide the guideline to guide governments and other stakeholders in developing and extending rehab services and delivering them equitably at all levels of health systems. Their aim was to strengthen the quality of the rehab service by advocating multidisciplinary workforce and the establishment of sustainable funding mechanisms to support and maintain service delivery and development. So again, this emphasis on service delivery. Our target audience it was intended for government leaders, health policies, workforce and training. But we as a team felt that it was very important also that they could serve as good practice statements. We had this very much in the back of our mind as another purpose. For individuals who are involved in rehab research, service delivery, the financing of assistive devices, professional organizations, academic institutions, and also civil society and NGOs. Okay, so how many people think that this is a tall mandate? No one thinks this is a tall mandate? It was a little daunting. And so to bring this about, what the WHO is, they developed a series of work packages that you were to bid for. So that original call that you saw was around different work packages. So as you can see, there was a work package on background, on leadership and governance, service delivery, rehabilitation workforce, assistive technology, financing, and information systems. And different organizations, primarily universities, bid on these work packages. We put in a bid for number 3, which was around service delivery, and with a PICO question. So PICO stands for Population Intervention Comparison and Outcome, and it's a way to formulate a research question. So the PICO question that we were given is what service provision models work for different health conditions, resource settings, bless you, phases to ensure the provision of rehab services. Okay, so that was what we affectionately called 3.1. And PICO question number 3.2 is what types of assessment tools can be used to ensure individuals' rehabilitation needs are adequately identified. Okay? And you see at the bottom that, again, always in our background, our target audience with low and middle income countries. So the first thing we did was develop a team. So one of the things that Andrea did, which was terrific, was that recognizing the fact that we're pretty spoiled where we're sitting at Dundas University, in the corridor of university that we're on, in terms of what the access that we have to this service provision is really quite phenomenal. And recognizing our target audience doesn't have anything like that. So Andrea recruited a number of, mostly they were fellows from representative countries to help give us the perspective that we needed. The other thing that I should point out, which is one of the very special things about working at the Institute for Work and Health, is you're about to see, again, how daunting this task was. And in a meeting that we have an operations meeting every other Tuesday, and I happened to mention in that meeting that we're feeling a little overwhelmed, because this was in addition to all of our day jobs, and we would like some help. And a number of our staff put their hands up and volunteered during their day job to assist us with this task. 2 of them are here, and Mary at the back, and Jocelyn. And we are always relying on our librarian here, who somehow does a great deal of magic. And she is also here, Quemby. So I'd like to recognize, I don't think anyone else is in the room that I've missed. Oh, Cynthia. Cynthia, are you here? Cynthia Chan, who ran some analyses for us to make sure that we were on track. The other thing that Andrea did was develop an advisory group. So this is very much a model that the Institute follows, is that we have a stakeholder advisory group, somebody that we can check in with throughout the process of a review. But in this case, because of the timelines, we checked in with them at the beginning and at the end, and they were extremely helpful. In particular, I think, Andrew, with our executive summary, is that fair? Because when you're in the midst of all of this, trying to bring it up to about 2 or 3 pages is a little challenging. So they were extraordinarily helpful with that. And the other context of this is the team that we worked with closely here for the PICO questions 3.1 and 3.2, but the WHO had already created an expert panel who would receive our evidence and then distill it once we had submitted it. I should also point out that one of the things that they loved about our report is the photo that's in the top left corner. And I think because it's important to see that we are doing this for individuals, and it's being done by individuals and not just this, mystery team in the background. So this is the Institute for Work and Health's model of conducting systematic reviews. There are some people in this room who've seen this a number of times, so I'll just gloss over it. The reason that I'm putting this out, showing this, is these are the steps of a normal systematic review. As you can see here, these are the steps of the systematic review on the side, and these are the timelines that we were given. So we submitted, I think if you're paying close attention, we submitted the work package at the end of January 2013. We received our contract in January 2014. And by the time we had negotiated our PICO questions, we started the 3.1 in September of 2014. We started 3.2 in July of 2014, and they were each due at December. So it was a bit of a whirlwind. And the reason, there were lots of reasons for that. Partly was to make sure that PICO was servicing the need. One of the things that we hadn't appreciated at the beginning is that when they spoke about people with disability, included physical and mental. We already thought this was rather daunting, and then it just kept getting. So that was an important clarification, and especially an important piece because of the search strategy to make sure that we were being very inclusive. We did refer to the report on disability a great deal, again, to make sure that we're using the language and servicing the needs. So we're going to focus on 3.2 first. So for the reason that for 3.2, where really this was identifying tools, you'll notice that when we conducted the search in July of 2014, our first N, so the first number that you should focus on, is that we had to screen through 16,541 titles and abstracts. If you think that's a lot, it is. And then we screened 2,643 full-text articles and extracted data from 123, and then prepared summary tables for 123 tools. We grouped them by disease, and then made sure that we flagged each tool as to whether or not it would be easily applicable to low and middle income countries. For 3.1, which was the focus on health services, as you can see, we ran the search in September. We looked at almost 9,000 articles, titles and abstracts, 700 articles. And originally, in the scope of the contract that we received from the WHO was to do data extraction. So we flipped the steps of our review on those 31 studies that we felt were of sufficient quality. They then later on asked us if we would do an appraisal of the quality and then prepare grade tables for each of those, which we did. The other thing to note is because of the amount of literature that we had to go through and the timeline that we were given, we decided to focus on systematic reviews first. So we looked at where there was a systematic review on topic, we looked at those first, and then we looked at, in the absence of systematic reviews on the topic, we then looked at randomized controlled trials and then observational studies. So you will see that the evidence synthesis comprises of systematic reviews, RCTs, and observational studies. All right, now to get to the fun part. This part was fun, actually. In case you think it wasn't, it actually was.
I'm so glad she remembers all the methods, because it went so fast in my memory. Oh my God, and we were running against the time and the clock, and but we did it, and we delivered on December 2014. How many pages?
473, and we delivered it on Christmas Eve.
Yeah. So you have, so this is what is in the brochure. And this is what the WHO put together. I didn't create this, but I'm very proud. I like the infographics. Of all the 9 recommendations that are here, the Institute for Health provided 5 out of 9. And the other 4 were provided by other 2 universities, one in the UK and in the US. So let's see one by one. Of course, I'm more familiar with the 5 that we created, and we provided the evidence and the draft recommendations, but I'll read for you all of them. So the first one is the countries that, imagine a country that doesn't have any rehabilitation services, and they would think, okay, I'm going to get some money from the World Bank, and I'm going to invest the money in rehabilitation. The first thing that comes to mind for these governments is, okay, I'm going to buy wheelchairs for everybody who needs wheelchair and give this, and this is rehabilitation. Well, that's not rehabilitation. But when they think about services, for them, people with disability are not working, therefore they need a disability income replacement, so they belong to the welfare department of the government. So we're going to give money for the welfare, and then they will give more money to people with disabilities. For them, this is rehabilitation. So we had to find some evidence, and as you see here, we found very low quality of evidence showing that it's better to do, because we didn't find any randomized trial that would compare, is it better to have rehabilitation services with the Ministry of Health, where health is delivered, or the welfare systems? There will never be a randomized trial on that thing. So very low quality. that was based on consensus, but Ontario and all the rest of Canada, rehabilitation is already integrated into the health system. So if you need rehab, you go to your doctor, your pharmacist, you see a nurse, you go to a hospital, it's integrated with the rehabilitation services, with the health services. But it's not so obvious for some countries. So that's what the first recommendation is all about. The second recommendation that we found, very low quality, but they made, the Guideline Committee voted, and they voted strongly in favor of this, is that rehabilitation services should be integrated into and between primary, secondary, and tertiary levels of health system. So what this means is that in many countries, there is a misconception that rehabilitation is a luxury agent, to people who have only significant, very important disabilities. And so they offer this like a selective service only in a tertiary center. They don't offer this in primary care. Yes, Emil? Everything. All of them. So we're talking about a vocational, prevention, we are talking about assistive devices, we are talking about mental and physical, children and adults, very global. Is that okay? So so because they were thinking there should be it's a system that should only be a tertiary system, a standardized, place in the country where the money will go. And so we found some evidence, but very low quality evidence, but the Guideline Committee made a strong recommendation, even based on very low quality evidence, that no, it should start in primary care, which is where people live, in community centers, even in schools. It starts at a very young age, and then transition. So there should be no barriers for referral systems. And again, when you think about Toronto, Ontario, we have this. Because the patients they flow easily from primary care to secondary and third care. So think about someone who has surgery, hip fracture, and they need rehabilitation. So they have a hip fracture at home, they go to emergency sends them to rehabilitation, either in hospital, inpatient rehab, or outpatient rehab. So they will do some rehabilitation close to where they live. So that's the transition from where people live that is important here. So rehabilitation not only happen in a luxury, a tertiary center. Again, this seems obvious to us, but it's not so obvious for these people. And then we are starting now to talk about the teams. Who should be involved in delivering this health, this rehabilitation? So a little bit about the workforce. And we found high quality evidence. There were randomized trials, many systematic reviews, many Cochrane reviews that looked at providing rehabilitation by a multidisciplinary team and providing by a non-multidisciplinary team, like one discipline or maybe two disciplines, and which one is better. So there was high quality evidence from multiple randomized trials across different disability conditions that multidisciplinary is better. However, we know this is going to be applied in Nepal, in the middle of nowhere, where who knows if they have one physiotherapist. And how can you then tell, okay, now you have to do a multidisciplinary team? And what we did was we found populations, and the Guideline Committee voted, and they recommend this. Here. For conditions that are chronic, complex, or severe, there should be an aim to have multidisciplinary teams to manage them. Not for everybody. So not every kind of disability will need multidisciplinary teams, but for those who are more chronic, complex, or severe, that should be a recommendation, and that's where the investment of money is well invested, is well spent. Another one. So should rehabilitation be offered just in the community or just in the hospital or on both? And we found some studies that looked at where is the best place to offer. And both hospitals and community settings are necessary. Again, because they were thinking, should we invest in building a hospital, a new hospital in the middle of our country, in the capital, and that's where everybody will come and travel and will have access to rehab there. But we know that for many people, traveling is hard. So having rehabilitation that is available, so teams that go to the community and deliver rehabilitation there, even to, to help these people to overcome the barriers that they face in their own communities. Because they may come to Toronto Rehab, where we work, and we say, okay, you should modify your house. But our teams also go to their houses, take pictures, bring back to the team and say, okay, this is how the stairs in their house look like. I don't think this person is going to be discharged safely because we need to modify the stairs, or we need to modify the ramp for them to get inside the house. So we need both. Also people should not be staying in the hospital forever because hospitals are very expensive. So there should also be a smooth and timely discharge. It's easy to keep these people inside the hospital, the patients like, staff is comfortable, but should be a transition to community. And because many people require rehabilitation even after discharge from the hospital, that's why this community-based rehabilitation is even more essential. So then you have how to continue the rehabilitation, especially for those who need for a longer time. So think about someone, 80, 90-year-old, who had a hip fracture. And they come to hospital, they spend some time doing inpatient rehabilitation, but they cannot spend 6 months in the hospital. And because it will be more independent, so at some point you need to discharge them, but they need to continue practicing their rehabilitation at home. And this includes people with developmental, sensory, including vision, hearing, or cognitive impairment. Okay? So we had a psychiatrist in our team. When we learned about that we were supposed to do mental disabilities, I said, oh no, that's outside of my scope of practice and my level of expertise. So we invited a psychiatrist from CAMH who helped us to look at cognitive disabilities. The other ones, now, should there be specialized units? For example, here in Ontario, you probably heard we have stroke inpatient units that are only specialized in rehabilitation management, acute, subacute rehabilitation of stroke. They're called stroke units. This is a concept that very few places in the world have. UK has, United States some places have, and Ontario has this. So people who work in that unit, they know everything about stroke, and it's the best care that someone can have for a stroke, for example. Spinal cord injury is another example. We have the Lyndhurst Center. It's part of the Toronto Rehabilitation Institute, that they specialize in spinal cord injury, inpatient, outpatients. So should we have recommendations that these rehabilitation centers around the world in low, middle-income countries, remember, they don't have any rehabilitation services yet, should we recommend that they start creating those specialized units? And then specialized units for what? For what kind of conditions? What kind of disabilities? We found very high quality evidence, and the Guideline Committee voted, and they made a strong recommendation that yes, specialized rehabilitation wards provide intensive, highly specialized interventions for restoring function to people with complex rehabilitation needs. So the recommendation is very long, and they go and talk about what are the complex rehabilitation needs, how you identify, how you measure if this is a really complex rehabilitation need or not. How do you decide if someone is more complex than the other person? Because you have limited capacity. Even in Ontario, not everybody with stroke will go to those inpatient rehabilitation services. But they say that in some instances, the results are superior to those that provide in general wards. So if you don't have a specialized unit, it's better to treat them in the general ward, like a neurology ward or orthopedic ward. But in the context of lower limb, if they have an amputation, spinal cord injury, stroke, or the care for the elderly people, ideally specialized units are better than general wards. So the idea is we give them the evidence, what's best. And the WHO will help them to put these recommendations into practice. And they told us that this guideline will have a shelf life of 30 years. Usually guidelines, clinical practice guidelines, you heard about, guidelines for diabetes, guidelines for low back pain, guidelines for depression. They usually have a 5-year shelf life, which means in 5 years you have to update and search at the whole literature because things change. WHO thinks that this guideline will have a shelf life of 30 years. That's how, because they don't expect that the evidence will change dramatically, but also is how long they think it's going to take for these countries to apply these recommendations. We're talking about major shift in investment of money, in building infrastructure, training the workforce. Okay. So those were the ones that we provided from the Institute. This one was provided by another team, so I'm not completely familiar with the evidence about this one, so I'll read for you. So they say that it was very low quality evidence, and the guideline committee made a strong recommendation. So they recommend financial resources should be allocated to rehabilitation services to implement and sustain the recommendations on service delivery. So how health services allocate financial resources significantly affects service delivery. So there should be budgets for rehabilitation. Makes sense, of course, yeah, but you need a recommendation. You need the WHO to tell them the obvious sometimes for them to do it. And the allocation of resources can increase both the availability and the quality of rehabilitation services and minimize out-of-pocket expenses, which is a significant barrier for service utilization. The other one, there was very low quality evidence, and the guideline committee voted conditional. It says where health insurance exists or is to become available, it should cover rehabilitation services. That applies for Ontario. Check your insurance, check your benefits, check if they include benefits for rehabilitation services. You'll be surprised how many of you doesn't include. So why not? Why disability should be treated differently? It should be treated as a health condition. Should not be treated as a luxury. So that's what this recommendation says. Health insurance is a common mechanism for decreasing the financial barriers to access health services. And yet, many insurances, they will cover your drugs, they will cover your surgery, they will cover your glasses. Well, glasses are kind of a assistive device, but they will not cover orthotics, they will not cover a wheelchair, they will not cover modification in your house. If you need to get in and out of your house, you need to modify the stairs to get in and out of your house because now you can't go up and down the stairs. Okay? And the last two were not really guideline recommendations. They were good practice statements, and they were about the assistive products. So, these are talking about, we're talking about any assistive device. Could be prostheses, orthotics, gait aids, could be wheelchairs, could be any assistive device. So financing and procurement policies should ensure that assistive products are available to everyone who needs them, and adequate training should be offered to users to whom assistive device products are provided. Not just giving wheelchair to everybody. Wheelchair is almost like a piece of your wardrobe. It has to be custom made, it has to be measured, it has to be each person who needs a wheelchair, they need a different wheelchair. You can't just give the same for everybody. So the impact of this, imagine the United Nations with the Convention of Persons with a Disability, the World Health Organization creating the guideline, the World Bank wanting to give money. So how is this coming? The WHO then created a document that is an action plan. So since 2014, they have this action plan, which is to make the world a better place for people with disabilities. And they have this 7-year plan to remove the barriers and improve access to health services and programs, to strengthen and extend habilitation, I like that word, habilitation, assistive technology, assistance and support services, and community-based rehab, and to strengthen collection of relevant and internationally comparable data on disability and support research on disability and related services. Because we need data. We need to know, when the World Disability Report came in 2011, some people had an idea that the numbers were high, but we're not expecting 1 billion people with a significant disability, and 80% of those living in low and middle income country. So it was an eye-opener that these countries are losing a lot of money by not rehabilitating these people. That's why they're doing this, right? Because the World Bank is going to finance those services, not because the World Bank is, you know, a good player. Oh, we're going to give money. It's because they're losing. People are becoming poor, and instead of being users of the welfare, now they can be contributing members of the society. They can, you know, be not just working, but being caregivers and taking care of their families. They can be productive members and happy and richer. So there is a lot of money being lost because these people are not receiving rehabilitation, plain, simple rehabilitation. So last month, no, in February, 2 months ago, the WHO did a stakeholders meeting. They invited a broad range of stakeholders, government, members of the WHO, the United Nations agencies, organizations representing people with disabilities, funding bodies, major professional organizations, research institutions, relevant international and non-governmental organizations. They all came to Geneva, and that's when the guideline was released. And the objective was to draw attention to the increasing needs of rehabilitation, highlight the role of rehabilitation, and to call for a coordinated and concerted global action towards strengthening rehabilitation in health services. And for those of you who like hashtags, this is Rehab 2030. Okay, thank you.